Okay, in this video, we are just going to look at some examples really quick of rhythm strips and try to decide if they are VTach, VFib, or SVT. So the distinctions between these three rhythms are actually pretty drastic, but sometimes when you're looking at a fast rhythm or you're just glancing at a rhythm, you can confuse one of these three with each other. So let's look at some and we'll talk about some quick ways that you can identify the correct rhythm in order to make the most appropriate treatment plan for your patient. So we're going to look for hallmark rhythm findings at a quick glance. So when we look at these three rhythms between VTach, VFib, and SVT, VFib has no symmetry, no repeating pattern of shapes. You can't discern a QRS complex from a T wave, from a P wave. You can't find anything that looks remotely planned or organized. Whereas VTach and SVT both have obvious QRS complexes, so you can pick those out. So if you see QRS complexes, then you need to ask yourself, are those QRS complexes narrow, meaning it would be an SVT or a narrow complex tachycardia, or are they wide, which would mean it's a wide complex tachycardia or VTach. And a lot of times you can just see with your eyes if it's narrow or wide without kind of squinting and zooming in and saying, how many boxes is it I have to measure? There are going to be occasions where you need to measure to determine if it's narrow or wide. And on those occasions, you want to put a little bit more effort into looking for other distinctive factors that are going to differentiate VTach from SVT. So let's get started. First rhythm. Do you see any symmetry, any repeating pattern? No, you do not. This is completely erratic and chaotic. Yes, there is large amplitude, there is large voltage, but it is not organized at all. So this is a coarse VFib, a VFib that is likely to respond to defibrillation attempts. Now this rhythm has symmetry. It has a pattern. It is nice and equal looking triangles. So you need to ask yourself, is this narrow complex or wide complex? And I think just glancing at it, it looks wide to you. You don't see the up and down movements really correlating within a couple small boxes, which is what we expect of a QRS. So this is a monomorphic VTach. Let's look at another one. This one looks narrow, looks symmetrical, and looks narrow. So this is an SVT. Now, if you wanted to decide what kind of SVT it is, you'd have to look for other distinctive factors that kind of separate it from one of the 7 subtypes. And I would say this is most likely a junctional tachycardia. This one's a little more difficult. So if you're squinting and you're zooming in with your eyes and you're saying, I'm measuring that QRS complex and it looks borderline. It looks like maybe exactly 0.11 or 0.12 seconds. You're correct. But when you look at the shapes of this QRS complex, it is 100% going in one direction. It's just an S wave, and your T waves are up here going the opposite direction. So even though this looks narrow, and it actually might even measure out narrow, I would say that this is a ventricular tachycardia, monomorphic ventricular tachycardia, because SVT usually has bidirectional QRS complexes, meaning you have both a positive and a negative deflection, and your T waves will always go upright. We have no positive deflection here. We only have negative, and we have discordant T waves. I would lean towards VTach. Depending on how stable your patient is for this one, you would want to get a 12 lead to really make the best determination. Is it torsades? Was that what you were thinking? It's a special VTach? No, this is another example of coarse ventricular fibrillation. Remember, torsades is a type of VTach, so it has a lot more symmetry than this. I can see your argument. It kind of looks like it gets bigger and smaller, but it is not clean. It is not a repeating pattern. It's very erratic. This is VFib. So this one again should be easy, symmetrical. It looks wide. If we measure it out, it comes out wide. You can see here again those hallmark findings of VTAC. So we have a monophasic R wave and a discordant T wave. So R waves are going positive, T waves are going negative. That really locks in monomorphic VTAC instead of SVT, even though this one does actually measure out wide. So this one looks narrow. Is it narrow? If you measure it out, yes, it absolutely is. So this would be a narrow complex tachycardia or an SVT. And what you would choose to call it of those 7 subtypes, we can actually see some P waves there. They appear to be upright. So I would say this is likely an atrial tachycardia. Hopefully you're starting to get the hang of it. This has symmetry. It has a nice repeating pattern. It's predictable. You can calculate a heart rate. Monomorphic VTAC. Even though it looks a little different from all the other ones, right? It still has the same characteristics. Symmetry, wide complex, fast rate, VTAC. This is a VFib, and this is a weird-looking VFib. It's like a slowish VFib, but there's no symmetry here. There's nothing going on except for a squiggly line, so this can't be anything else. Another one that's a little bit too easy, right? Hopefully this came to your mind. VTAC. Nice and quick. Quick and easy. Monomorphic VTAC. Versus... is this one torsades? No, it's not. This is coarse ventricular fibrillation again. So don't go looking for torsades. Really, when you see it, you'll know that you see it. You shouldn't have to squint and turn your head sideways and say, do I see that twisting ribbon pattern? Chances are you don't. Chances are you do not. VFib is common. It's every day. It's every code. Torsades, you'll be lucky if you see a handful of times in your career. How about this one? Looks torsades-y, but is it? Nope, not torsades. It is another example of coarse VFib. There's no symmetry. There's no symmetry. There's no equality. There's nothing that is a repeating rhythm at all here. It's just a squiggly line. So this one's hard. It looks narrow complex. It measures out narrow complex, but it does have that monophasic R wave with discordant T waves. So this is another one. I would probably say, depending on how stable your patient is, a 12 lead would be warranted to really rule out or rule in which rhythm it is. I would lean towards SVT on this one just because it's super narrow. It's like 0.06 measurement, which would be almost impossible for a ventricular rhythm to accomplish. In terms of subcategories of your narrow complex tachycardia, I would call this AVNERT because I do think that you can see some P waves right before that T wave there. So this would be a paroxysmal SVT, assuming it stopped kind of on its own in less than 30 seconds. What were you thinking? If you said VFib because it doesn't look super symmetrical, okay, but there is some symmetry here. So this is a VTAC, and I would even go as far as to call it a polymorphic VTAC. I would not, however, go as far as to call it torsades to points. We don't really have that pinching, the complete, right about here where it's the smallest in true torsades, that should be almost like 0. You should really see it pinch down to almost 0, and you don't. So this is just a polymorphic VTAC. So now that you see these two rhythms side by side, hopefully you can start to appreciate the differences between a nice, beautiful, symmetrical, monomorphic VTach, which then turns into a very unsymmetrical, chaotic, erratic ventricular fibrillation. So another challenge. Hopefully you said narrow complex tachycardia or SVT. This is actually a rapid AFib because you can see irregular R to R complexes. And right here where it slows down just enough, you definitely do not see P waves and you do see squiggles. So this is a rapid AFib. And then what you have right here is a PVC. So you can see that the QRS looks completely different from the other QRSs. So this is that person's wide QRS. If you measure it, it's probably borderline, probably 0.12 compared to their normal atrial generated QRS complexes. It's important to note that you cannot have PVCs with VTach. If the ventricles are already controlling the heart, then you just have a ventricular rhythm. So you either have VTach or you have idioventricular, but you wouldn't have PVCs on top of that. So that's one thing that really makes this one easier to separate from some of those other ones. Also, if you look at our R wave, so this is a monophasic R wave. It only goes up. Well, actually, there is a baby Q, so it's not. It's biphasic. We've got a QR. So that kind of confirms SVT versus VTach, and also our T waves are also going up. So they are matching our QRS complex, which happens in atrial rhythms and does not happen in ventricular rhythms. That was it. Hopefully that helped you differentiate.